Welcome to Academy of Ultrasound and their echocardiography online program. My name is John Sheldon. I'm one of the instructors here at the Academy, and this particular lecture is going to be talking about week 5 in Echo 232, coronary artery disease, specifically chapter 15 in your Feigenbaum book. When we talk about coronary artery disease, we're talking about coronary arteries in the heart. Specifically, the same arteries that they have bypass surgery on. And if your patient has coronary artery disease, then there's certain functions of echocardiography to try to help determine how bad that disease is. It's the most common form of organic heart disease encountered in adults. It's typically the result of atherosclerotic disease and includes symptoms of stable and unstable angina, which is chest pain, acute myocardial infarction or heart attack, ischemic cardiomyopathy, which is a cardiomyopathy due to the coronary artery disease, with congestive heart failure and sudden cardiac death. The American College of Cardiology, as well as the American Heart Association guidelines, are listed in your book in table 15-1 and 15-2, and you need to be comfortable with them. It's the recommendations for echo in the diagnosis of acute myocardial ischemic syndromes. Ischemic means lack of flow. Things such as diagnosis of suspected acute ischemia or infarction not evident by standard means, evaluation of baseline left ventricular function, evaluation of patients with inferior myocardial infarction and clinical evidence suggesting possible right ventricular infarction, assessment of mechanical complications and mural thrombus. Class 2, patients with ongoing ischemia. Class 3 is the diagnosis of acute myocardial infarction already evident by standard means such as EKG. Table 15-2 is the recommendations for echo in risk assessment, prognosis, and assessment of therapy in acute myocardial ischemic syndromes. Class 1 is to assess the infarct size or the extent of the jeopardized myocardium. In-hospital assessment of ventricular function when the results are used to guide therapy. Class 2 is in-hospital or early post-discharge assessment of the presence, extent of inducible ischemia in the absence of baseline abnormalities. Reevaluation of ventricular function during recovery, an assessment of ventricular function after revascularization, assessment of late prognosis, years after acute myocardial infarction is Class 2B, and Class 3 is a routine reevaluation in the absence of any change in clinical status. If you'll notice, there are some notes down at the bottom pertaining to up here at the top. You have some areas that deal with subclasses such as exercise or pharmaceutical, pharmacologic stress echocardiography, dobutamine stress echocardiography, and so on. So be aware of these. You don't necessarily have to memorize them, but these are the different reasons that you may be asked to do an echo on a patient that has suspected coronary artery disease. The pathophysiology of coronary syndromes. Normal left ventricular wall motion consists of a simultaneous wall thickening and endocardial excursion, so the cavity decreases in size in a relatively symmetric manner. and that's shown in 15-1 and 15-2. So these are diastole at top, systole in the bottom. You'll notice that you're maintaining a nice circular pattern to the wall. It uniformly contracts. The hierarchy of functional abnormalities occur as a result of interruption in coronary blood flow. Fancy way of saying that one of the walls is not going to move normally if there's interruption of coronary blood flow. 15-4, figure 15-4, is a demonstration of the ischemic cascade, outlines the sequence of events as the magnitude of ischemia increases. You have normal function, you have perfusion abnormality that would be picked up on a nuclear scan, diastolic dysfunction, relaxation abnormalities, abnormal DTI, strain rate, visibility of abnormal wall motion with a stress test, EKG changes, chest pain, and infarction. Those are the cascade or the ways or the particular path that ischemia takes. The hierarchy. So resting blood flow is preserved until a coronary artery stenosis approaches approximately 90% narrowing. At a lesser degree of stenosis, resting flow is preserved, but coronary flow reserve may be reduced at increased demand, such as exercise. Underlying principles of stress echo are designed to unmask coronary artery stenosis. Immediately after coronary artery occlusion, abnormalities in diastolic function occur. Figure 15-5. Within seconds of a coronary occlusion in the bottom panel, it immediately goes to the lower E, big A. It immediately switched to a reversal of the E to A ratio once you occlude the coronary. Abnormal mitral valve inflow with a reduction in E wave velocity and an increase in A wave velocity will lead to abnormal relaxation pattern. Loss of systolic wall thickening, decreased endocardial excursion in the region of the obstructed coronary artery. These are all signs that you've had a problem. Note the lack of thickening in the anterior wall and the anterior septum compared with the normal. These areas here, up at the top, compared to the bottom. The anterior septum at the top where the arrow is, note the lack of thickening compared to the bottom at systole. If a coronary artery obstruction persists for a threshold period, typically 4 hours, myocardial necrosis ensues and a persistent wall motion abnormality will develop. Depending on the presence or absence of collaterals and duration of the occlusion, a series of identifiable wall motion abnormalities may be found. If flow is restored before the onset of myocardial necrosis, variable degrees of recovery of function can be expected. Recovery of function may not be immediate, but rather delayed due to myocardial stunning, which is easily demonstrated on echo and represents persistent wall motion abnormalities after restoration or restitution of coronary blood flow. So you take them to the cath lab, you put a stent in, they increase or return the coronary blood flow, and you can still pick up wall motion abnormalities on echo due to what they call myocardial stunning. There is a 48 to 72 hour delay in recovery of function. Occasionally, this can be delayed as much as weeks to months. The phenomenon of repetitive stunning, the myocardium is subject to repetitive brief episodes over time, which will result in prolonged post-ischemic dysfunction. Following complete coronary occlusion, a series of events known as remodeling occurs. For roughly 6 weeks, necrotic myocardium is replaced by fibrosis and scar tissue, that is thinner and denser than normal myocardium, but has similar tensile strength, making it less likely to rupture. Maybe regional dilation present that results in ventricular aneurysm, figure 15-8. This is an apical aneurysm where it gets real bowed out. See the arrows where it bows out? This is an apical aneurysm in a real live echo picture. You'll notice the bowed out section at the very top where it's kind of ballooned looking. Aneurysm is a regional area of an akinesis or dyskinesis and scar that has abnormal geometry in both systole and diastole. So it doesn't move. Akinesis is not moving. This is in contrast to a regional wall motion abnormality that has normal geometry in diastole. So for detection and quantification of wall motion abnormalities, you have regional left ventricular wall motion can be analyzed in table 515-3. You have the eyeball assessment, normal versus anormal. Read through these, and it talks about what we can actually look at. Your area changes, your left ventricular volumes, quantitative with fractional shortening. There's a lot of different things we can use to try to determine wall motion abnormalities. You can get a wall motion score. It's a unitless hierarchical number proportional to the severity and magnitude of wall motion abnormalities. Most commonly used assessment of left ventricular systolic function is the ejection fraction, commonly referred to as EF. Volumes are frequently indexed to body surface area, so you'll have to take the patient's height and weight to allow for normalization. Precise calculation of the ejection fraction requires a biplane approach to volume determination. More than one. You have 4-chamber view and a 2-chamber view, and you'll do EF calculations in both. Two-dimensional imaging has replaced M-mode echo for evaluation of global and regional wall motion. Most commonly used method of volume determination is the Simpson's rule. The endocardial boarding in diastole and systole is outlined, and mathematically a series of discs is generated. What you need to be aware of is that with Simpson's, you go into the 4-chamber view, you get a good LV shot in the 4-chamber, and you basically draw a line around the outside of the endocardium, and it fills it in with these little lines. Each one of them refers to a disc. Then you go into your 2-chamber view, and you do the same thing. And the machine will calculate an EF, and it's referred to as the Simpson's rule of discs. It gives you a volume, and that's how it determines the diastolic volume minus the systolic volume, gives them a percentage or an EF. It is a biplane methodology, and it's necessary if precise measurements are required. Two-dimensional area measurements of the short axis at the papillary muscle level is a reasonable global assessment unless there is isolated apical dysfunction. So if you can't get other views and you can show the doctor a 2D short axis, parasternal short axis at the level of the papillary muscle, that gives a reasonable global assessment, because he can see all segments of at least that segment, all portions of the wall, all the way around in that segment, unless you're expecting apical dysfunction. Multiple schemes for regional wall motion assessment is in table 15-3. Let's get to table 15-3. And that's supposed to be on page 442, and I've gone past it. Bear with me just a second, ladies and gentlemen. I've gone past the 15-3. We'll move back up here real quickly. Wall motion analysis methods. We were already looking at that, and I apologize. Again, it gives multiple schemes. That's the same thing we already talked about. Assessment can be undertaken on purely qualitative terms. Example, an eyeball assessment, as whether it's normal or abnormal, hypokinetic, akinetic, or dyskinetic. Hypo meaning less motion, akinetic meaning no motion, dyskinetic means that it's out of sync. Truly quantitative analysis is a radian shrinkage analysis. Nobody in the field that I'm aware of does that. Additional qualitative indicator of abnormal ventricular function involves assessment of ventricular geometry. Again, nobody in the field that I'm aware of, short of research people, do that. A normal left ventricle is considered a cylinder with an apical cone. The geometry is therefore bullet-shaped with gradual tapering of the diameter towards the apex. The apex has very limited motion during the ejection and filling phases. Apex only moves briefly during the isovolumic periods. Significant apical motion on an echocardiogram means the transducer is not over the true apex. It's called foreshortening, and it rounds off the apex. That's something we'll talk about in ScanLab. The bullet-shaped geometry is noted on the apical 4 and 2-chamber views as well as subcostal. In the short axis view, normal geometry is circular. Parasternal long axis view, the normal geometry is slightly concave curvature of both the ventricular septum and the inferior posterior wall. Normal geometry is schematicized in figure 1513. Let's go down to 1513. And this gives you a pretty good idea of what the views look like. Your parasternal is concave, circular in the short, bullet-shaped in the 4-chamber and the 2-chamber. Abnormal geometry is most apparent in the apical 4-chamber and may involve rounding of the apex or asymmetry of the apical shape. And that's on figure 15-15. These are some different normal views, aneurysmal views, regional dilation views. Again, regional dilation. These are different views that you can see in a typical or in an echocardiogram that would be abnormal views and show abnormal wall geometries. That's it for this session. Look for part 2 of this video, also under week 5, in an effort to not make the videos too long.